And may I request Dr. Aniruddha Maiti to, take up from here on. So he will basically be talking about, managing iatrogenic breaks and retinal touch. So Dr. Aniruddha Maiti, please.
Thank you, Devdulalda. Well, I will be showing you iatrogenic break and how to sound. Deva? Okay. Let's see few cases where this iatrogenic complication has happened, and then we will have videos how to prevent this. So this was an vitreous hemorrhage with TRD. Nasal TRDs at times are very bad. It's very difficult to take out with the cutter. The only option is a bimanual option, which should be tried. This membrane was this retinal membrane mainly was not taken up by the cutter, and then we use this faucet. So nowadays the using of the faucet should be minimal because we have got very good instrumentation and we can prevent this iatrogenic break. In order to remove this membrane from the nasal side, this break was created. So this can be prevented by the bimanual. Now this is how it should be done, where we can prevent this iatrogenic complication. You can see a very tabletop TRD case over here, even more difficult than the previous one. Meticulous dissection, dissecting out the membrane, or rather the plane of dissection is very important. Once we get the plane, we can do a conformal cutter delamination. We have to go along with the shape of the probe so that we don't touch the retina. Sometimes the planes are very difficult to get, and we can use this cytodissection or dissection to make this plane, and then the job becomes. This is how all the diabetic cases should be approached instead of using the faucet. Another technique where we can prevent the iatrogenic break. Nowadays, due to the good instrumentation, we don't use much, but very severe, large fibroscular membrane, this is the only option that you have to approach by NDS and do a bimanual dissection, where you can manage the membrane without causing any iatrogenic break and managing all the technique, typical technique, small snip. You have to go underneath the membrane and we can remove the membrane in the retina. Once it is removed, once it is detached from the cases, how to prevent a retinal touch. Generally, it is not that common, but it can happen if you are a little bit close to the retina. As in this case, almost the case was over. In the last bit, touched the retina, and it was a little bit big. This kind of break actually can be left because in the posterior pole it doesn't make any difference. But if you feel that it is a full thickness one, do a laser because absolutely no prognosis of this patient. But this kind of break can be left behind. But we need to be very careful about and very sure about the aim of the eye. And this is an unusual case. There was an touch by the soft stick because we are pushing the DVD and the assistant was new and we pushed it hard and the soft stick actually went inside and hit the retina. So the only good part was it was directed towards not in the center of the port. Whenever you put the dye into the directed towards the nasal side or very controlled way, drop by drop fashion. That is the main. Regmetrozine and RD are going. There are sometimes cases like this. Bullet RD very close to the retina. You see with a 20K when you are doing the peripheral diffraction. You need to be careful. This is how yes, this break has happened because the vacuum was more and there was always better to reduce the vacuum, especially in the 20K cutter, to prevent. The other way to prevent it is to stabilize depress it with a depressor. Depressor in many cases we are using, but depression actually makes that part of the retina stable. The chances of iatrogenic break is less. That will prevent any iatrogenic. This kind of detachment, that is a combination of fractional detachment and reg RD. You need to take care of the fractional membranes in diabetic cases first before stabilizing the retina as because you have to address both the parts, the regulation RD as well as the fractional part. You have to resect the membranes first, then do a PVD, mark the break. You can see once the membranes were released, the other part of the retina was quite full. So there was a big break. Same way you put the PFC. Now things become easier. Combined art. So these are the following few tips which we can follow and prevent any iatrogenic complications.
Thank you, Dr. Aniruddha. That was wonderful. We are open to questions, but one first question I would like to ask is, what would be your guidance for creating a plane or searching for the plane?
I think all diabetic cases are different. Some cases we need to actually approach from the center, from the desk, and some where the PVD has not happened, you have to actually uh, put the triamcinolone and do the vitrectomy and search for the ages where we can actually start the vitrectomy. And in order to do so, sometimes we can get it while inducing the removing the vitreous. In order to get it, we can use this following tools also, like you can use the proportional reflux, or we can use the bimanual technique if it is very difficult or very large fibrovascular membrane. But I think put triamcinolone, do the vitrectomy, automatically you can actually get the age and start the dissection from there.
One other thing that you've shown is in a macular hole, we often have, we touch the retina, or while removing the ILM with the forceps, we can grasp the retina. So this is something that is not to be scared of, as you have shown. But maybe for some of the beginners, it will be prudent to tell them that whether you use gas or oil in these cases. So what would be your choice? Do they need to put in oil?
I don't think any oil is necessary for this case. The gas
Yeah.
is good enough.
Right.
Sometimes there is always a tendency, I've seen people are mingling around the edge of the macular hole to make sure that in order to tuck the ILM, but that's actually not required. But in order to do so, sometimes the hemorrhage happens. I can give one example, like there was an hemorrhage, one of my colleagues had an hemorrhage and the hole closed. Later on, that patient had a CNVM from that side. So tucking or mingling around the edge of the macular hole should be avoided, because nowadays we give flaps and that is good enough to close the hole instead of this tucking the ILM into the hole. That's not required actually.
Yeah.
Yeah. Yeah. Actually, laser in the posterior pole, I showed two cases. One was the touch with the soft tape. That was a big one and it was oozing. And it was nasally also. Nothing happens. That patient got 6/6 vision also. But the other one, we could have opted for not doing a laser. Because it was just a touch and you are putting a tamponant and it's in the posterior pole. So you might not do it at all.
So iatrogenic macular hole during retinal hole during macular hole surgery is relatively common. So it should not happen.
Because we
So yeah, it happens because most of the time our focus is to the macular hole. So one of my cases that my fellow that injected triamcinolone during vitrectomy, and in the cannula there was some triamcinolone particulars there, and my assistant gave me the cannula, same cannula, and I injected the dye, and that triamcinolone particles, they hit the retina and they created a large hole. Fortunately, it was just away from the macular, central macula. So these are certain situations that
was this staining under air?
no, I injected under fluid only.
Fluid only.
So this is one situation like your
Because this is another complication what Dr. Borman was telling. If you stain it under air, there is a chance of jet injury.
Yeah.
So it is not required actually. The staining
So-
under fluid is equally
So
good.
these are certain, and as Asmita
But
has
there are
shown that
chances of
there is a lattice
complication.
that break was formed. Na? So in such situations, maybe what I do is I just go to the from posterior to anterior, from the to the anterior edge of the lattice, and then from anterior to posterior, from the posterior edge of the lattice. I think this is a technique that we can avoid some hole formation or break formation in the lattice. What do you feel?
In fact, you have to trim it
Yeah.
because you cannot take entire vitreous from the lattice. You have to shave
You
it.
cannot remove anterior vitreous.
It is not possible. You have to shave it and with the minimal vacuum.
Yes,
so
better
that
not
it
to
doesn't-
pull like, as we do in a
because
PVD.
the scurvulent retina will come and there
If
will
you
be
pull it from
iatrogenic.
posterior to anterior, definitely there is high risk of break formation.
Break
So
formation, yes.
yeah, so I go to the
side.
periphery and then I come from anterior to posterior towards the lattice, because the anterior vitreous is relatively easy to remove from the lattice.
Thank you,